let's continue with the thoracic trauma, and we just finished a little bit with tension pneumothorax. Hemopneumothorax, again, we're trying to get the lower apices of the thoracic cage because we can drain the blood out there. Now remember, it's probably going to be both. We probably have a tension pneumo, and we probably have a hemopneumo if that is the case. Now, there are no real great signs of external signs on the patient that would tell you that's a hemopneumothorax or hemothorax. It just may mean that they might have pink frothy sputum as they are breathing up, but that could also mean that there is compression in the chest wall that's causing blood to be pushed back up. So we're looking at diminished lung sounds again, plus or minus. Some other finding that might indicate that there is bleeding that's going on. Now remember, it's all signs of pneumothorax or tension pneumothorax, and we probably would have to follow our local protocols to determine whether or not we are able to go ahead and initiate the fourth intercostal or fifth intercostal space, either mid-axillary or mid-clavicular line. Now, injury to the great vessels. We talked about this slightly before this. Coarctation, not the coarctation, but the aorta is anchored, as is the heart. It swings as the pendulum to the ligamentum arteriosus. And in a type of incident where mechanism of injury is a frontal collision with high speed, we see the heart hanging in the chest as a pendulum, and as it twists and it shifts, it can cause a laceration to the aorta, and the aorta then can bleed out. Now, there really isn't any great treatment for that. It's just understanding the higher probability based on your mechanism of injury. Let's go back to myocardium now. So as far as myocardium, based on the mechanism of injury, we could have cardiocommotors or cardiocommotion, which is the blunt chest wall trauma that causes the chest, or the myocardium rather, to go into significant cardiac arrhythmia. It was potentially hit during the relative refractory period. We all know about that. It causes the heart to go into ventricular fibrillation, and we need to get them defibrillated to treat that. Now, if there's bleeding in the myocardial sac, which we already talked about, then we look at trying to relieve that. Now, our local protocols don't allow us to do this, but in future that potentially there is a chance, we want to introduce a large bore needle and a long length needle. We're looking at probably using something at least 2.5, 2.25, 3-inch needle that goes in, and we usually try to go into the subxiphoid process, so just under the rib cage in the hypochondrial. And we're looking at going on the left subxiphoid process. We're advancing the needle in with at least a 10 to 20 cc gauge, a 20 cc syringe, drawing back as we instill that needle in. It should be above the diaphragm at that point. And as we advance it in, we're actually aiming for the apices of the heart, and as it goes in, we're trying to enter into the pericardial sac. Now, you'll get blood if you go into the ventricle, you get blood if you go into the right ventricle or left ventricle, but we're trying to get into pericardial sac so we can withdraw that fluid, and so it doesn't cause compression of the pericardium, decreasing our outward flow and passage of blood flow into the right ventricle across to the left ventricle. As we know, the right ventricle feeds the left, but left ventricle is what flows blood out, and so we're trying to get the needle into that area. Now, if you get too deep, you will see that you irritate the myocardium. When you irritate the myocardium, you'll have some arrhythmias. Now, we don't have protocols for that, so as I mentioned, this is all in anticipation that maybe you might have to do this. As we are going in subxiphoid, it is towards the left side of the xiphoid process. We're aiming the needle about 30 degrees, and we're aiming it towards the left shoulder as you go in. And you're going in and you're drawing on the plunger of the 20 cc syringe. Now again, you'll get blood if you hit the ventricle, but you'll have arrhythmia, so you need to draw back. And hopefully you get blood that's in the pericardium and you're not causing arrhythmia. and you'll see changes on the EKG. Now the EKG changes when the pericardium or myocardium is being oppressed or occluded or compressed by blood in the pericardial sac, the pericardial tamponade. You'll see what we'll see is electrical alternans, and we'll see low voltage criteria again. So if you see low voltage criteria across all your 12 lead, and at least in the first, the limb leads and the augmented leads, which we normally would have, if you see low voltage criteria, if you see small complexes on the QRS, think that it might be fluid filling up. Now, if it's not an acute process, people can have pericardial effusions, and they don't necessarily have the pericardial tamponade things that you would see, the JVD, the muffled heart sounds, and the low voltage criteria. And we can review now Beck's triad for this. Let's move on to diaphragmatic injuries. Now, if we have an injury to the diaphragm, we know that the gastric contents will go back up into the lungs, or not lungs, into the thoracic cage. And if it does go up into the thoracic cage, what's going to happen is that we'll have decreased ability for the lungs to expand. So you have some tachypnea, but you'll have a scaphoid abdomen. You may have plus or minus other signs of tension because there's a lot of extra pressure going up into the lungs and volume is much less. Then you have hypoventilation because the lungs can't expand. Now, it all depends on whether or not you have suspect based on the mechanism of the injury. Now, the only thing that you can do is to try to overinflate those lungs, and hopefully you are keen on that and you can intubate them. Esophageal injuries, these are very obscure. I can tell you that unless penetrating trauma, or there is some type of Mallory Weiss or some kind of esophageal injury, it will be hard to determine whether or not you have this. However, if you intubate the esophagus, you may end up getting a lot of air into the thoracic cage because air now is not going into the gastrum. Now, on top of that, whatever products is in the stomach and through the esophagus may leak through what we call the cardiac sphincter or the lower esophageal sphincter. Now, hopefully that's not the case. However, just think about it as we intubate. You will have some CO2 if they've been doing some bag valve ventilation prior to you getting there. Air will go down through the passage of least resistance, and that air may be mixed, and so it will have some CO2. So that won't be a great indicator. You can't use the esophageal detection device, EDD, because if the esophagus is severed or fractured or lacerated, it will allow air to just fill up that bulb. Hopefully when you intubate, you will be able to visualize anatomy. Again, we talked about it as you go in. You see in the hard palate, soft palate, you see in the hypopharynx, you see the uvula, you get past the base of the tongue, you see the lower, actually the oropharynx, you see the oropharynx, you get down to the hypopharynx, you see the epiglottis, you're able to see the valvular space. Hopefully you're able to lift up the epiglottis and see the glottic opening and then place your tube in there. And then go ahead and ventilate, and we should have positive sounds in the lungs, right and left lung fields. We should have negative epigastric sounds, and we should see good end-tidal CO2 exchange. We should see end-tidal CO2 monitoring. We should have a good waveform. We should also have good color change.